I'm not predicting the future, I'm just pretending.
Well, you know,
Wait a minute. There's a story here. 6 chapters. Where's everybody? Trying to get me to relax. Give me another question. I'm going to take you to my work. Put around me.
It's okay, Doctor, because I introduced people.
I'm not thinking you can't introduce yourself, but it means there's a whole gap of people. I've been here when the
dermatologists are coming over.
I don't want to give you trouble. I want to listen to what you have to say. I don't want to give you trouble. Come into my office last night. I saw it. I come into the office.
Anybody coming from NICU? Good afternoon, everybody. I am Dr. Harijit. I'm part of the committee that organizes the grand rounds, and it's usually my task to introduce the speakers. Today, I happen to be the speaker, so I'll introduce myself with a couple of sentences, but I'm sure that most of you know me. Being a neonatologist, I take care of newborn babies. I did my medical education in India, then did my residency in the same place from Medical College Trivandrum. Then did fellowship, it's a short residency in United Kingdom, followed by fellowship, 3 years fellowship in neonatology there, 1 year fellowship in PICU. Then decided to subject myself to more torture, so crossed the big pond. Other side is always green. Coming to this side, 3 years of residency, and again 3 years of fellowship, some 4 years in between working in deprived area for green card, then subjecting myself to some nice torture in lab for the last 6 years here. So let me start on a problem that is celebrating its 50th anniversary this year. 1967 was the year that the term BPD or bronchopulmonary dysplasia was coined, and the first publication came that year. It's good to start with a case report to get an idea of the magnitude of the problem or how it evolved. It was August 1963. A lady named Jacqueline was hospitalized in her 34th week of pregnancy at the Artis Air Force Base Hospital. Her fetus was in distress, but labor did not progress. Her husband, Jack, was concerned. On August 7th, she underwent a C-section to deliver a baby boy who weighed 4 pounds and 10.5 ounces, 2.112 kilos, good weight. Jacqueline and Jack named him Patrick. After delivery, the baby developed difficulty in breathing, which did not improve despite oxygen therapy, the only therapy available at that time. The baby was then rushed to Children's Hospital of Boston, a leading center of RDS at that time. Unfortunately, despite the best medical efforts, The baby died 2 days later. The death of the newborn baby devastated the family. The couple, however, managed to overcome the crisis. But Jack was fatally shot 4 months later in Dallas, Texas. The couple is survived by their daughter. This event brought to the attention of the world the problems of the preterm. Naturally, New York Times came up with an editorial, and as I said, it gripped the attention of the world. So in Patrick Kennedy's obituary in New York Times, it was stated that the only treatment for a victim of what was called as hyaline membrane disease at that time is to monitor the infant's blood chemistry and try to keep it near normal levels. 50 years plus down the lane, we are still doing exactly the same, but we have some devices to do that. Thus, the battle for the Kennedy baby was lost only because, again, I'm quoting from New York Times, the medical science has not yet advanced far enough to accomplish as quickly as necessary what the body can do by itself in its own time. So, what the body can do by itself in its own time is the key when it comes to management of most of preterm neonatal disorders. Looking at the magnitude of the problem, if you look at the top 7 countries with the greatest number of preterm births, United States ranks number 6th, and within this, if we look at the disparity between the high income and low income settings, less than 10% of extremely preterm babies, that is less than 28 weeks, they die in high income settings. In other words, 90% of such babies do survive. Whereas, more than 90% of such babies in low income countries die within the first few days of life. So, further looking at the rate of infant mortality, it's about if you look at the total mortality, the national average is only 6.9 per 1,000 live births. But among African American populations in the US, in the year 2000, it was 14.1 per 1,000 live births. So it's slightly more than double. So the rate of prematurity is double. This is after the reduction of teenage pregnancy and the cocaine problem in the 90s. Even after that, among African American population, it is 14.1, is double that of national average compared to his deprived Hispanic or deprived white population. So it is a problem of the deprived. It is a problem that reflects the disparity in healthcare. Again, looking at extreme low birth weight babies, 25 to 40% of extreme low birth weight babies, that is those with a birth weight of below 1.5 kg, they develop BPD. So if we look at what happened over the years, there was advent of technology and other improved measures related to ventilation, and a whole gamut of management changed. The most sentinel change was brought in by the use of antenatal glucocorticosteroids. So prenatal steroids reduced the incidence of respiratory syndrome, decreased intraventricular hemorrhage, and an overall reduction in mortality also was noticed. So antenatal steroids played a wonderful role, the most important therapy or the most important therapeutic intervention in the last 25 years. Then consequently, postnatal systemic corticosteroids were used. They were effective in reducing BPD, but you had to trade in your brain for that. So you decrease BPD, but there's an increased incidence of cerebral palsy. So in other words, the first attempt to decrease BPD by using postnatal steroids had a major setback in the form of increased cerebral palsy, and BPD did not budge. Then came extensive use of surfactant, which is very effective and efficient in the prevention and treatment of respiratory distress syndrome of the preterm babies. The preterm baby is born with surfactant deficiency. When administered surfactant, their respiratory distress goes down and they come off the ventilator or other breathing support pretty quickly. So that is effective and is proven. But use of early surfactant did not decrease the incidence or prevalence of BPD. Then came other measures related to nutrition, such as sodium reduced use of sodium, reduced use of fluid, so that there is decreased fluid retention, decreased pulmonary edema, thereby decreasing the injury that can be sustained by an edematous lung. So a non-edematous lung is more compliant and suffers less damage. So that was fairly effective. Then after these measures from 1990s to 2000 and going further resulted in reduction of BPD. So at 4 weeks, significantly more infants in the fluid restricted group and the general ventilation group survived without radiographic signs of BPD. In this context also, I would like to mention that as far as the diagnostic criteria of BPD is concerned, the diagnostic criteria underwent major changes over the last 50 years. The latest one being physiological diagnosis, in other words, requirement of oxygen supplementation or ventilation. So at that time, radiographic sign was the diagnostic criteria, so there was some reduction. Then, going further, non-invasive ventilation, such as use of continuous positive airway pressure, or other measures of non-invasive ventilation, whereby you are ventilating the baby using a ventilator but not intubating the baby as such. This, in the initial data, suggested that the infants treated with non-invasive ventilation compared with conventional ventilation, there was a lower risk of combined outcome of death and BPD. The major paper, or the most noticeable study in this, was one comparing Boston Children's Practice versus Columbia University Medical Center, where Columbia used more non-invasive measures and had less BPD. In this setting, high frequency ventilation came in as a marvelous form of general ventilation. Though it's considered to be a more gentle form of ventilation, from a BPD point of view, there's no conclusive evidence. So these were the changes that came in. The physicians began feeling good because you are not intubating the baby. You are ventilating the babies less. You are using general forms of ventilation. Fluid restriction is there. We are using more antibiotics. We are restricting fluid. Sodium levels are kept low. We have TPN. We are giving more fluid. Now more babies have their own individual rooms. So a lot of changes have come. So physicians started looking at what happens to BPD as the children get discharged from the neonatal unit with the diagnosis of BPD, but what happens to them thereafter. Early studies, of course, came in the mid 80s and early 90s. That's when the major studies came out. The first study suggested that a 2-year follow-up study of infants with BPD was compared with premature infants who had moderate RDS, and it was found that severe peripheral pulmonary obstruction, in other words wheezing, was found in 80% of BPD infants at 1 year and 40% at 2 years of age. So by 2 years, even the wheezing comes down. So there was a tendency for babies with BPD to grow out of BPD. In other words, symptoms go down as they grow up because lungs grow along with the children. Then another study came out in 1987. That was a major paper, first major follow-up study from Dr. Bankalari, who has studied extensively the disease of BPD and especially from a follow-up point of view. So Bankalari's paper came in 1987 in Journal of Pediatrics. He found that there was decreased airway conductance during the first 6 months, which had reached to 85% of normal at 3 years. Lung compliance, 50% of normal at 1 month, also increased with growth and almost became normal by 2 or 3 years of age. To give an idea of timeline, 1987 was a year that AZT was introduced, in other words, recognized by FDA to be used as a drug for HIV. Western blot also got accepted by FDA as an investigation for HIV. So it was expensive at that time and hence invited criticisms. Then, further, Bankalari study, he said that infants with BPD had significant lower functional residual capacity in the first 6 months of life, but not later. FEC decreased in infancy, but caught up by 3 years of age. So gradual improvement in maximal expiratory flow, So in summary, lung volume increases normally in the first years of life, but obstruction does not seem to resolve so readily. So this was the picture in late 80s and early 90s. In other words, with all the measures that were instituted, such as gentle ventilation, fluid, and whatever technology and advances had to offer then, the BPD was a problem from which the children were growing out of. Very good. Then came Epicure study from Europe, main study. Epicure 1 was 1995 and Epicure 2 was 2006. They found that at 11 years of age, especially the 2006 study, 56% of the children had significantly decreased forced expiratory flow and 27% had positive bronchodilator response. That means they had asthma. So reduction in lung function was seen more in severe BPD. It was more in severe BPD, and 78% of the extreme preterm children had airway obstruction, ventilation non-homogeneity, gas trapping, and airway hyperresponsiveness. That is at 11 years of age. So this completely negated what Benkallari found earlier. Then further studies came from Perth. Professor Doyle is his publications. He works at Melbourne, but most of the publications on BPD follow-up, especially long-term follow-up, 18-year-old follow-up, young adult follow-up from colleges came from Doyle's publications, and that too from Perth. Perth has an advantage: fantastic follow-up. Perth is surrounded by nothing. If you are born in that region, you have to go there for follow-up. Otherwise, you run the risk of traveling through the desert and you won't get anywhere. So, Perth has probably the best follow-up data in the world. Newborns, preterms born there, they go to school there, they go to college there, and geriatric studies of BPD is also going to come up from there. So they found that. So Doyle had the advantage of following up babies. He followed them at 8 years of age. The same babies were there at 18 years to be followed up. And he found that there was a dramatic decline in lung function. When you are measuring at 8 years of age, and then again at 18, the lung function plummets. Normally, we reach the peak of our lung function. The peak of our lung function is achieved at 25 years of age. Thereafter, it's a plateau. It's going to go down or plateau. You are not going to go up from there. In these children, at 15, the decline starts. Then they go on to develop emphysema. So young adult emphysema is probably the sequelae of BPD. These young adults with BPD, they go to college and they smoke. Rapid decline in lung function. So these studies have now shown to us what we believed earlier was wrong. That was because most of the severe BPDs died before, even moderate to severe BPDs, they died. With the advent of technology and ventilation, more and more survival came, as a result of which the prevalence of BPD changed. So, is this still a problem? Is it worth studying this? If it's a problem that's going to go away, it's not going to go away, that's what we thought. But if only if the prevalence is not great, why should you even think of it? So we get about 500,000 babies born every year as preterm extreme low birth babies in North America. In 2005, the annual financial toll of society due to preterm birth was at least 26.2 billion. Incidence has risen by 36% over the last 25 years. So, BPD is such characteristic, though it's characterized as a rare disease, agree, 10 to 15,000 new cases appear per year, most severe cases. We are talking about severe BPD. So, but the impact of BPD spans the individual's lifetime, which if estimated to be 65 years, places the estimated prevalence of BPD at 1 million in a few years' time. This is NICHD data. So, it is increasing in prevalence simply because of improved survival. So, the stress was on preventing prematurity. That was the stress from the year 2000 to 2010 to early 2012, 2013. If you look at the NICHD goals, prevention of prematurity was there as one of the prime goals. Now it has gone down in the order a little bit. So the Holy Grail, though Holy Grail is the prevention of prematurity, that has proven elusive. So if that is not achievable, then we must always have some goals and we must always believe that it is achievable. Then only you can achieve it. So the prevention of prematurity was initially considered as achievable. It has now shifted to prevention of BPD. In other words, primary prevention of BPD. So, but BPD is not straightforward. BPD involves development of lung. So if you think of lung, it's an organ where epithelium and endothelium have to meet so that the gas from the atmosphere reaches the blood. So you have epithelium, endothelium, and there is something in between. So there must be, all these three elements should come together in the right time and function normally. So that results in an efficient gas exchange area, the lung. So you have epithelial pathology, you got endothelial pathology, you got mesenchymal pathology. So impaired, in addition, you need normal blood vessel development. So impaired development of lung microvasculature can happen. Then elastic tissue, collagen tissue, the connective tissue is very much part of lung. Those tissues have to be formed normally. And extracellular, most importantly, extracellular matrix remodeling. So multiple components happen there. It's not just one cell that is going wrong. It's a whole organ with all its cells. And naturally, it's not, you cannot point out to one etiology. Infection is a contributing factor. Hyperoxia is another contributing factor. Ventilation, volutrauma. So to just name a few. So we are dealing with a complicated pathology that is very much complicated in nature at cellular level and also at etiological level. The lungs go through various stages of development, but the key problem is the primary alveoli that is formed are very simple spherical structures. And the surface area contributed by the primary alveoli, they are large simple alveoli and which are not fully functional. The lungs have to go through a major stage of development. That is, this simple spherical structure has to undergo multiple septations to form multiple small spheres, thereby exponentially increasing the surface area to get a good functional lung. So the formation of septa is very critical, and this process is not simple. Formation of septa, whether it's a blood vessel that initiates septation or whether it's the epithelium that initiates septation, that is type 2 epithelial cells multiplying to form type 1 epithelial cells, what exactly is happening there? Everything is happening together. The type 2 epithelial cells, the mesenchymal cells have to become type 2 epithelial cells. These type 2 epithelial cells have to multiply to form type 1 epithelial cells. Surface area has to increase. The blood vessels have to undergo angiogenesis. The new blood vessels should sprout out, project into these epithelium, push them out, form septae. In between there will be matrix. The matrix has to stabilize. It has to thin at the right time so that there's not much of resistance for gas exchange. So this process starts by about from the point of view of lung development. The critical stages of lung development start by 22 weeks and go on till about 8 years of age. But the most critical or the exponential increase in formation of alveoli take place from roughly 28 to 30 weeks. There is a late canalicular, early alveolar stage, early saccular stage to alveolar stage. So spans from 28 to 30 weeks to about 36 weeks. It's the most critical period. Things have to go wrong at that stage. If that doesn't happen, if that is not happening, the alveoli remain as simple and there will be few alveoli with reduced gas exchange area. That is the primary pathology in BPD. So if you look at the current therapies, it all started with nutritional supplements and then attempt with drugs. Nutritional supplements started off with carotenoids, otherwise the vitamin A family. Carotenoids play a significant role in the protection of cell membranes and lipoproteins against reactive oxygen species. So they are powerful antioxidants. They have got peroxyl radical scavenging ability. They are generated due to various mechanisms of cell metabolism. Lipid peroxidation is one mechanism. Regular electron transport chain in mitochondria generates 3 to 4% of reactive oxygen species. So that it's formed as part of normal physiology. So nutritional supplements got tried pretty early, and it was found that initial trial showed that there was significant response, and the number needed to treat to prevent one case of BPD was 15 infants. So the American Academy of Pediatrics accepted it as evidence level 2B, came up with a policy statement where you could use it. But then came vitamin A shortage, and a publication last year looked at the same units that were using vitamin A supplementation earlier. They found that BPD rates remained fairly stable. So it might have helped, but is it really needed? In addition, there were concerns of sepsis and necrotizing enterocolitis. So the final conclusion, the final recommendation is that further evaluations are necessary before vitamin A can be recommended as a cornerstone. Other nutritional supplements such as fatty acids, especially the long-chain polyunsaturated fatty acids, can prevent BPD. Small studies, nowhere near recommendation level. Then L-citrulline and amino acid, it's used to treat pulmonary hypertension because citrulline is part of the arginine pathway which generates nitric oxide and hence causes vasodilatation. Can be useful if you dilate the blood vessels, more blood supply to developing lungs. So more blood supply means more development, more blood vessel formation. At least you are taking one component of ischemia away. Will that help? Postulates. Then came coffee. So caffeine, early administration versus late administration. There were concerns from animal studies related to caffeine because caffeine acts by inhibiting adenosine receptors in the brain. Adenosine receptors play an important role in the development of brain. So there were concerns, but still it was considered as a safe drug, and a CAP trial did take place. So it was found that early use of caffeine compared to late was very useful. A big meta-analysis showed that the risk of death came down a bit, but BPD came down. Odds ratio in those children who used caffeine was 0.5, so it comes down by half. Also BPD or death comes down by half. As a result of which, and early caffeine was not associated with risk of necrotizing enterocolitis. So caffeine is there in the recommendation as something that could reduce BPD. From a brain development point of view, these children did very well at 2-year follow-up, but at 5-year follow-up, no real difference was noted. So caffeine is there in the recommendation. In the caffeine or the coffee family is pentoxifillin. This is again a drug that effectively causes vasodilatation as well. So this in human trial, 150 children were given pentoxifillin. There was a reduction in BPD, but still there is insufficient evidence to support its widespread use, unlike caffeine. Then, of course, every disease under the sun has steroids in being used in this armamentarium. So 22 randomized control trials were done. Steroids did help reduce the flow obstruction. So flow obstruction associated with airway smooth muscle constriction and inflammation was alleviated through inhaled therapies. BPD is actually caused by, the wheezing in BPD is actually caused by airway remodeling, especially of small airways. It's not, they do not have increased atopy. They can get atopic asthma, but they do not have increased atopy. They do have remodeled airways. Steroids do not help remodeling of airways. So in other words, it's a temporary phenomenon, can relieve some inflammation, that's it. Plus you get the satisfaction that you're doing something. On top of this, bronchodilators get used extensively, both beta agonists as well as anticholinergics, piperactropium. So inhaled corticosteroid therapies all serve as excellent symptomatic therapies. But do they have an impact in the long term? Do these therapies affect BPD? No. Then of course, we like to use antibiotics, right? Whether it's ear infection or BPD, we use antibiotics. Urea plasma urealyticum was isolated from babies who are having a BPD. It's responsive to azithromycin. Azithromycin was used. Of course, it reduced the risk of BPD in extremely premature babies, 2 or 3 studies. But further studies, meta-analysis showed nothing. Some cases of hypertrophic biliary stenosis got reported. Again, it is there in literature, but not a recommendation. Diuretics, extensively used in the NICU. Here there are control trials examining the use of thiazide and spironolactone. Spironolactone showed some promise, only some promise, but General use of thiazide diuretics decrease pulmonary edema, one by decreasing the overall fluid overload, and two, there are epithelial sodium channels in lung cells. So probably they could act, there could be a dual action. So there is improvement in pulmonary mechanics, no doubt, but so it's a short-term improvement. Long-term wise, no benefit. So other side effects such as ototoxicity, electrolyte disturbances, ototoxemia, azotemia, even in Lasix, which is not used, which is never advised as a long-term medication, can cause nephrocalcinosis. So diuretics again offer short-term improvement but not long-term. Then came a major publication in New England Journal of Medicine from Dr. Ballard of Children's Hospital of Philadelphia. Fantastic study. It was a thoroughly done study. For the first time, nitric oxide was shown that it improved survival in babies dramatically without BPD at 36 weeks post-menstrual age. This is conforming to the guideline, to the newest guidelines to diagnose BPD, physiological criteria. But what happened was that after that there were so many studies and large meta-analysis failed to show any benefit. So far there's only one study. But since that study was published in NEJM, got so much of prominence, and the study got replicated all over the world. But thus the results are not being reproducible. So currently there is insufficient evidence to recommend the use of routine use of inhaled nitric oxide therapy in preterm infants. Then again, another drug that causes vasodilatation through the same mechanism of nitric oxide, sildenafil. It's used in pulmonary hypertension, but as far as neonatal persistent pulmonary hypertension or pulmonary hypertension secondary to BPD is concerned, not of much use. It's a selective phosphodiesterase inhibitor. In animal studies, it promotes alveolar growth, mitigates inflammation, reduces pulmonary hypertension. Small pilot studies have shown that it reduces pulmonary vascular pressures in children with severe BPD, but nothing else. It doesn't help BPD. Then use of late surfactant is still being tried in many places. Early surfactant did symptomatically improve RDS, but did it decrease BPD? No. Then the thought was, why don't we use a late surfactant and improve compliance of lungs in the late stages? Will that help? Again, studies are going on. So far, nothing has come out. Then after trying anti-inflammatory, antioxidants, food supplementation, people started looking at oxygen. Probably this is the real culprit. Once you catch the real culprit, you are okay. You should be able to solve the problem. So far, whatever we are doing, probably we were not focused enough. If you focus on oxygen, everything will be okay. Because the immature lung is exposed to a non-physiological substance that it gets exposed to after birth. And that non-physiological substance is air. Once a baby comes out, gets exposed to air. This oxygen baby is not used to handling this level of oxygen. So lungs get exposed to at least 5 times of oxygen concentration if you look at the air. So then probably once you concentrate on that, you can wipe off all the losses that happened earlier, and hereafter it's all going to be full of gains. Plus, there is scientific basis to it. It's not without basis. Free radicals are formed extensively, even physiologically. A preterm baby has got poor antioxidant defenses. In addition, you are exposing this baby, a simple exposure to air is 5 times physiological concentration. Most of these babies get 50-60% oxygen, so it is many times. Free radicals are formed extensively. Lipid peroxidation, peroxide radical and peroxidation products were studied in various whatever fluid that could be collected from an intubated preterm. All showed that there was increased free radical. So they looked at superoxide dismutase level. Superoxide dismutase converts free radicals to hydrogen peroxide, a much innocuous, much less innocuous chemical compared to a real free radical. So superoxide dismutase was reduced in these babies specifically. So it was postulated that if you are supplementing superoxide dismutase to these babies, there should be improvement. Animal studies in piglets showed fantastic response. BPD was completely reversed. This followed human studies. Is it going away? Okay. This followed human studies. The main trial was in 2003, the superoxide dismutase trial. This trial was terminated early because 34% of children given superoxide dismutase developed BPD compared to 26% in controls. So what happens? Is the science wrong? Science can't be wrong. If I am the one who devised this plan study, can I be wrong? No, I am smart. I can never go wrong. It was assumed that hydrogen peroxide can be handled by the babies. But hydrogen peroxide has been converted to water by catalase. It was again assumed that there will be enough catalase. Probably that's where things went wrong. Many babies died and developed BPD. So now a combination of superoxide dismutase and catalase has been tried in piglets. Successful. Studies are coming. Be careful if you are signing the consent. So this was 2008 AD. 1967 is when BPD started, 40 years down the line. If you talk to neonatologists about BPD prevention, this is what the response would be. And nutrition supplements, vitamins, vitamin A and E was also tried. Vitamin E was tried and babies died. That trial had to be stopped. Fatty acids, amino acids, diuretics, steroid, antibiotics, coffee, pentoxifillin, late surfactant, nitric oxide, sildenafil, nothing. Okay. Again, hope, yes. Came in the form of mesenchymal stromal cells. So we are now moving away from pharmaceutical agents. All those are toxins. Their drugs are all dangerous. So let us look at biologicals. Let us look at nature, naturopathy. So mesenchymal stromal cells are multipotent cells and have diverse but restricted ability to differentiate to a specific lineage. The study came from Stella Corbanas, it was published in Blue Journal. It was initially a mouse study where mesenchymal stromal cells were administered to these babies. Exact mechanism not known. They interact with innate or adaptive mechanisms, but fantastically they aid fantastically in lung repair and regeneration. How? Not known. They restore alveolar epithelial and endothelial permeability. In other words, they restore the lungs to near normalcy. So they appear to function in a paracrine manner because they interact, they aid in lung repair by secretion of cytokines and other growth factors. They restore permeability. Those aspects were known. Rat pups were studied, and the intratracheally, these cells were administered intratracheally or intraperitoneally. So intratracheal administered were better in preventing lung growth, and there was a decrease in alveolar apoptosis. So its protective function was, and it was found that these cells do not get grafted into the host tissue. So if you have the external cell that is getting grafted, you could develop graft versus host disease, rejection of transplant cell and such other problems. So these cells were not getting accepted by the host tissue. So if it's not getting accepted, if it's not getting incorporated in the tissue, then it is staying outside the tissue and doing something. That led on to believe, okay, this is something, the cell is making something. Then it was found that it was indirect action, paracrine effect. So infusion, so the cells were grown in media was taken out and administered to animals. It was found that there is dramatic response, and this was sustained at 6 months down the lane. So something coming out of the cell. This led on to further interest. So we don't have to use the cell for grafting. The cells can do something, and that's something we can use. Endothelial precursor cells. Endothelial cells are essential for formation of blood vessels. Precursor cells play a big role in angiogenesis. So endothelial precursor cells and colony forming cells were used. These are circulating cells. And what happens in newborns, when you expose newborn mice to oxygen, these cells get depleted. When you expose adult lungs to hyperoxia or stress, these cells double. So in other words, probably deficiency of these cells is what is contributing in mice. Human beings, nothing similar was exactly found. So again, they restore vasculature. They can be isolated easily. So it's a potential therapy. Conditioned media, as I said, was used, and it was found that it decreased. It was used in bleomycin model of BPD. They promoted vascular growth, but did not promote alveolarization. That's okay. All studies need not condition cells from endothelial colony forming cells, not from mesenchymal cells. So conditioned or cell-derived medium is being studied now, because unlike administering cells where you cannot determine the dose, conditioned medium you can measure the concentration of the compounds in the medium and you will be able to standardize it. As a result of which, purified cell-derived medium from mesenchymal stromal cells, they found that exosomes are present in the media, secreted probably by these cells. Exosomes, it was found later that the exosomes display therapeutic benefit, as a result of which you can standardize the media. You can say this many exosomes are there. So dose standardization is possible. So attention is moving in that direction. Amniotic epithelial cells have been used by surgeons for wound care, and also there is some promise here. Another protein is the club cell protein. In other words, all I am saying now is about biologicals, because after 2008-2010, new pharmaceutical agents have not been patented for the use of, in other words, there's no patent pending. Old chemicals are still there, user patents. So biologicals came. In this context, I happened to join UIC and happened to join a lab that was doing work on lipid signaling. Lipid signaling has been studied extensively in neurology and in multiple sclerosis. Gilenya, the only drug available for multiple sclerosis, acts by inhibition of lipid signaling pathway. This has been studied in sepsis models of adult lungs but not in neonates. So we used, initial experiment, we used newborn mice that lacked an enzyme which makes a critical compound named sphingosine 1-phosphate. When we genetically knocked out that enzyme which makes this compound and exposed the mice to oxygen, there's a dramatic improvement in BPD morphology. Then we looked at the mechanisms and found that by inhibiting this compound, we are able to inhibit the formation of ROS. So far the therapy concentrates on quenching of ROS or extinguishing the flare after the flare is already formed, after the flare is lit. So this follows a prevention rather than cure kind of, is better than cure kind of philosophy. That's what we found. So at that time, Pfizer came out with a compound PF543, which was released into the market in 2012-2013, with no specific use stated, because it was used for cancer therapy trials in cell therapy. It did not kill the cells. So it was released in the market, which luckily coincided with our use of genetic knockout mice. This is the most specific inhibitor known. So we used that and we found that it was very effective. So this formed the basis of the current grant that I am in, which is the Chancellor's Innovation Fund. This is the compound which got 4 critical regions and a small molecule compound and which can be easily formulated and administered in the form of aerosols or other forms, and has got enough side chains which can be modified. Only if you modify the side chain, you can take away the structure pattern from Pfizer to UIC. So what we did was that we used this for neonatal hyperoxia experiment where we injected intraperitoneally, and this is the vehicle, means control. This is the drug, room air. When you expose the mice to oxygen, large deformed alveoli similar to BPD is formed. You get improved alveolarization. Then we use the drug locally, administering it intratracheally in adult mice, and found that there is increased inflammatory infiltrate when exposed to hyperoxia in adults. That was reversed. So it plays a significant role in prevention. And looking further into mechanisms, we found that this is cell study. The brightly lit cells show formation of reactive oxygen species. When we are using PF543, we are able to decrease the reactive oxygen species. The first study, we published it in American Journal of Pathology in 2013. And this mechanism further we published in June this year in American Journal of Physiology. And a follow-up on a different mechanism is, experiment is almost complete, being written up. So, looking at therapy, there are 5 rights of a therapy. You have got to get 5 things right for a putative therapy to be successful. 1, you have to have the right drug that is not toxic, that is effective. The right drug, you must be able to administer the right drug in the right dose. You can't just administer some cells and say that this is all going to work. No, you must have the right dose. Then, you must have the right route of administration. Suppose for BPD, you have a wonderful drug and you have to administer it through bone marrow all the time, 3 times a day for 2 weeks. Not going to work. So, right route. Preferably, intratracheal, local administration must be possible, intratracheal. It must not corrode the airways. So, right route is important. Then, right time. When do you give it? Soon after the baby is born? Is it delivery room? In NICU means it's forever. Baby is born and then you have a long period of time. Is it at the beginning of alveolarization, or is it halfway through, or should you continue? You must have an idea. Efficacy studies must be relatively foolproof. Animal studies in multiple species must be done, efficacy point of view. And no animal model ever is equal to a human disease, but at least physiological parameters if they are meeting, and histopathological parameters if they are there, if you have correction, then fine, you can get somewhat, you can get close to that. Then again, there should be the right patient. Who is the patient? Who is the sickest one? Who will benefit from this drug? So we must have, in other words, early indicators that could suggest that such a patient is going to develop this problem. So determining. So the 5 rights of therapy is essential to get anything correct. And another very important thing to remember is that a physician or a scientist, when a trial comes out, good, read it, but have your doubts in mind. When you are a scientist, do your experiments, can look at the results. Yes, good, but when you are extrapolating the results, keep your doubts alive. You don't have to write it in your manuscript, but yes. So, preventing BPD? Nobody knows. Thank you. Any doubts? Thank you.
How good are the
Yes, Sir Frank?
Good.
how good are the studies? I mean, it's so many variables. How large is the N? In that meta-analysis that you pointed out early on, are you happy with the data?
One of the big meta-analysis that came on caffeine and also about 56,000 patients. So there are big studies supporting caffeine from the BPD point of view and from a short-term brain development point of view. Yes.
And our criteria on BPD has changed to what?
Physiological now. At 36 weeks of gestation, your dependency, if you're oxygen dependent, then you are again cutoff of 30% is there, whether to call it mild, moderate, or severe.
Okay,
So
you're happy with that?
Yeah, it is no physiological criteria. It's oxygen dependency. That is the criteria. Yes.
2 points. First of all, I don't understand how you skipped over from the alveoli septation to the fact that all the disease later on is mostly airway disease. You never mentioned any alveolar disease later in life. All the sequelae seem to be airway disease. At least that's how they're measured.
Yes.
What's your comment on that?
Yeah. And the definition of BPD involves is actually reduced gas exchange area due to alveolar growth arrest. So that is BPD.
But that's not the sequelae.
But it is there. That is there. In addition to that, the known sequela is airway remodeling. So these two go hand in hand. And this airway remodeling was what was discovered early on because the patients were wheezing. Even those who were having mild to moderate BPD, the survivors in the 80s were wheezing. So wheezing is there, airway remodeling is there. But BPD per se is alveolar growth arrest, oxygen dependency. That is the problem. This is actually an accompanying problem, but it's very much there.
So it's a surrogate for
Correct.
the alveoli.
Yeah.
But you mean it's an accompanying problem because
Yes.
it's secondary to response to the lung something, or you think it's the same damage? Let's say
It's
the
the same.
hyperoxygen,
It's
the
the same.
oxygen damage.
It's the same damage. Whatever is causing BPD causes that damage as well. It's the same.
Okay, that's what I want to know. I know we don't know for sure, but that's what you.
Yeah. That's what I meant.
What oxygen level do you keep the babies at in the nursery now?
Depends on-
No, I didn't mean that. What PO2 do you keep?
It is oxygen saturation that we go by.
Yes, what is it?
Relates.
Sorry, oxygen
No
saturation.
problem.
Yeah.
Oxygen saturation we go
It's
by.
all the same.
Lessons learned from the STOP ROP trial taught us that if you are using oxygen to keep saturations above in the high 90s or I would not use a cutoff in the high 90s, the babies do develop severe lung disease.
Got it.
As a result of which, the cutoff is preferred in the 88 to 92 range.
What about lower?
85 to 95 was also published, but the lower oxygen study got into trouble because such babies on follow-up had poor development.
That
so
was
brain
a big
development.
scandal. That was a big scandal.
Big
when they
scandal.
tried to reduce it.
Birmingham, yes.
That's it. Thanks for reminding me of that.
Thank you.